doorbell. Very good morning to you students. Hope you have enjoyed your Sunday. But the time is running short. So we'll be going today to the 2012 theory long questions. In our last lecture we have considered 2014. In 2013 all the questions were in fact repeated. So I have not considered them. Okay, so the questions are here somewhat different. What they've asked first, they have asked everything in detail regarding the laparoscopic surgery. And remember, the laparoscopic surgery is a buzzword of today. Nobody can escape the laparoscopic surgery and its approaches. Second is wound healing, third is perforated duodenal ulcer, hydronephrosis, acute pancreatitis, which you already covered, and the management of neoplasms of kidney. So let us start from question number 1. It shows principles, limitations, intraoperative, postoperative problems of a laparoscopic surgery. Plus, we will also consider the major indications and the technique. You should all be aware of the technique because they are asking in practicals. Just go back to the history. Professor Udwadia from Mumbai, he is the person who did first laparoscopic cholecystectomy in India. It came in around about 1992. So what are the principles? This approach is totally different. In fact, if you want to remove a small appendix, you have to take a large incision. Small gallbladder, large incision. So this concept is a minimal access surgery. This is MAS. And what are the principles? In acronym, they have straight, it is IVITROS. 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 If you follow this, you will know what are the principles of this surgery and what are the different applications. What I stands for? Insufflate. Insufflation for creating a space. Because you are going into unknown territory. This creation of space will allow the surgery to take place. Okay. This is insufflation. V. Because you are visualizing the structure which are collapsed. You have to make the magnification. Visualization of the tissues, anatomical landmarks and the surgical environment needs magnification, and that magnification will come with the help of camera. Identity. You have to be able to identify specific structures for surgery. It is a specific surgery. Triangulate. What is this concept? There are usually 3 to 4 ports, and the triangulation means you have to make an optimal use of all the instrumentation, and ergonomic means the science of movement. Ergonomy. Here your instruments should not clash to each other and they will have a free function. So that is called as a triangulation. R stands for retraction. In open surgery you have got so many assistants, here it is restricted. So you should have something to improve your access and go for the retraction. That is done by instrumentation. Operate. All the things which are doing in open like incision, suturing, anastomosis and fusion. Fusion means bringing them together. They are all done under laparoscopy. That stands for O. And sealing is S for hemostasis. You are sealing either hemostasis, you are doing cautery, whatever it is. So all the functions of surgery done in open surgery are replicated in laparoscopic surgery. So it is IVITROS. What is MAS techniques? In general, there are many things now available in MAS technique. They are, in short, laparoscopy, thoracoscopy, endoluminal endoscopy, perivisceral endoscopy. So things are vast now. In fact, every organ can be approached endoscopically. For perivisceral, it is a mediatoroscopy, retroperitoneoscopy, and retroperitoneal approach to kidney and aorta. So your approach, these are aorta is retroperitoneal. You can operate it retroperitoneal. Kidney also can be operated. So this is advancement. And principles are IVITROS. Remember seriously. Okay. But the question asks limitations of a minimal access surgery. There are certain limitations. But with the advancements of all the biomedical instrumentation, that limitations has become very minimum. There may be contraindications, but now the MA surgery or laparoscopy has got unlimited. But to summarize the limitations, as a question is asked, what are the limitations? The basic limitations is it is a technically very demanding surgery, and sometimes you have to be very slow to perform. Speed is sometimes hampered with laparoscopy. More important than that, you must be used to it. So the learning curve of a laparoscopy is much longer than the open surgery. Because in open surgery, what you are getting is a tactile feedback. That means your fingers are touching the structure and you get the feeling of that. In laparoscopy, you are not getting the feeling of a structure. The endoscope itself is so advanced, you are many times not aware of the advancement. So one should be available for that. And this is very difficult navigation. You must learn the navigation in laparoscopy. So it is a limitation. Next is significant problems in hand-eye coordination. Whatever given in red, you remember and you are required to write then your answer. Okay. Next is significant problems of hand-eye coordination. You have to learn laparoscopy in a younger age. Above 40, it is very difficult because there is a problem of eye and hand coordination. Major problem here is the psychology. If you have started with laparoscopy and some major problem arises, one should be open-minded and must know when to go for conversion. What happens in young students or super specialists? They are afraid, or what the word says, they are ashamed of opening, and that ashame must be avoided. And that ashame of going for conversion is unjustified. So major disadvantage of laparoscopic surgery is absence or loss of tactile feedback. Okay, so this is in short limitations of a minimal access surgery. So this is a graph. Limitations: reliance on a remote vision and operating system, loss of tactile feedback, dependence on hand-eye coordination. This should be very good. Difficulty in hemostasis, because once the bleeding starts, getting clear field is very difficult. It is a totally new technique. You must be master of that. And the extraction of large specimen is difficult, not impossible in a laparoscopy. So what are the contraindications? Frankly, there are no absolute contraindications. Relative contraindications are compromised cardiac status, because this patient required what is called as a pneumoperitoneum, and that may compromise the cardiac status. Peritonitis, actual inflammation pus in abdomen, is a relative contraindication. Previous abdominal surgeries, the laparoscopy is made more difficult. Not a contraindication, a relative contraindication. If patient have bleeding disorders, you must be very well aware and must be cautious. Morbid obesity. In fact, this is not a contraindication. For morbid obesity, laparoscopy is a treatment of choice. We are all doing bariatric surgery by laparoscopy. So morbid obesity, the laparoscopy is a treatment for it. Some problems arises in third trimester pregnancy because a field of vision or the abdominal cavity is maximally occupied by the uterus. Major problem arises in portal hypertension. Here also the difficulty is, if bleeding start, it is difficult to control. So these are all relative contraindications, no absolute contraindication. In short, you must be aware of a basic laparoscopic technique. Just try to remember few important things. What are the common instruments used? Remember 3 or 4. Laparoscope. Laparoscope is of two types. First is front weighing, another is side weighing. It has got a 0 degree or 30 degrees. 0 degree is most commonly used. The light source is a cold light source, either a halogen or xenon. We are commonly using halogen lamp. we need a very good camera. This is a 3-chip camera we are using with a very high resolution. Now, video monitor is a must. We are all operating while looking at a TV screen monitor, and then we are operating. Equally important, CO2 insufflator. Without that, surgery is not possible. Okay. Instrumentations like hooks, speculas, clip applicators, needle holder, endostaplers. Endostaplers is very commonly used. Varus needle and irrigation. Base is trochers. How do you enter into abdomen? Trochers are of different sizes, 10 mm, 5 mm, and there have different reducers. So these are the basic instruments: laparoscope, either side viewing front, light source, CO2 insufflator, camera, video monitor, and hand instruments. All these instruments are combined as a hand instruments. Okay. Now, how are we going to start? Commonly, now we don't apply. It is a head of the table is lowered. To start with, to insert the varus needle, we make the head end low so that the introduction of a varus needle will be easier. Nowadays, varus is not very commonly used. Here we are using pneumoperitoneum, which is created by an open approach. There are two methods. One is a varus needle method for insufflation, another is called as open method, where by a small supraumbilical or through umbilical incision, we are opening the peritoneum and inserting a trocar and cannula. At the same time, we will go for pneumoperitoneum. In varus needle, pneumoperitoneum is created first and then the trocar is introduced. In open method, trocar is introduced first and pneumoperitoneum created afterwards. CO2 is most commonly used gas for insufflation. The reasons are readily available, cheap, it doesn't go for combustion, burning is not there. It is easily absorbed by the tissues and it has got a high diffusion coefficient. That is why it is absorbed or reabsorbed in the blood very fast. So the gas of choice is CO2. Sometimes nitrous oxide. The pressure required for this is 15 millimeters of Hg. Laparoscopy is inserted through umbilical port, that is 10 mm. Additional ports all are usually of 5 mm, sometimes 10 mm size. And these ports are placed in such a way that we have to avoid triangulation. Okay, so this is in short what is required for knowing about the pneumoperitoneum and the laparoscopy technique. So what are the advantages? You must be able to write down these basic things in laparoscopy. Okay. Diagnostic laparoscopy indications are all acute pelvic conditions, ovarian diseases, tubal pregnancy, infertility, staging of malignancy, biopsy, chronic pain, barium studies whenever negative, and nowadays they are going for needle laparoscopy. Very small 2 mm size needle is introduced along with that camera. So by this simple 2 mm needle you can see everything. This needle may take the place of laparoscope for diagnostic purposes. That will be revolution. And what are the procedures commonly done? Write down few. Hernia repair, splenectomy, fundoplication, vagotomy, Nissen's fundoplication, colectomy, hysterectomy, now very commonly done. Most commonly done procedure is gallbladder and appendicectomy. These two are most commonly in our country: appendicectomy, gallbladder, hysterectomy, and bariatric surgery nowadays. And one should not be surprised, after 10 years, bariatric surgery becomes the most commonly performed operation, more than appendicectomy. Higher end, what they are doing? Prostatectomy, thyroid, aortic aneurysm, single vessel bypass. The bypass we should go for open technique, heart opening. Now that is also done by the thoracoscopy. VATS is video assisted thoracoscopic surgery. That is done for the pulmonary pathologies. Laparoscopic hernia, paraumbilical, angina, inguinal. So these are the procedures nowadays along with all renal procedures, all kidney procedures or procedure of hydronephrosis, even nephrectomy is also done. Okay. So, what are the problems? The question is the problems and post-operative problem, intra and post-operative problem. Mainly these problems are because of mechanical and instrument inefficiency. If there is any problem with instrumentation, there will be problem. So you have to go for safety precautions. In our theory lecture, if you remember, we have considered what is coupling. Coupling has to be avoided in any circumstance. By coupling, you mean the inappropriate application of current or cautery to intestine. You must have a very good knowledge of all instrumentation and you must avoid organ injury. When it occurs during the port insertion, like injury to major vessels, bowel, mesentery, and liver. Some patient may have CO2 narcosis, hypoxia. Sometimes there can be bleeding or trauma to gallbladder or trauma to CBD causing bile leak. Subcutaneous emphysema is common. Cautery burns are very common. Sepsis, sometimes infection into subnephric abscess, pelvic abscess. Wound infection is comparatively very low as compared to open surgery. Even mortality is very minimum at par with open surgery, 0.5%. So this is all win-win situation for laparoscopy. So what are the advantages? Advantages of MAS, minimal access surgery. One, decrease in wound size, reduction in wound infection, decrease wound pain. This is why there is a lot of patient acceptance to this surgery. There is no wound, there is no scar, there is no compromise with your day-to-day life. Discharge patient on second day and nobody knows he is operated. So patient acceptance is very high. The problem of wound, bleeding, herniation, nerve entrapment and wound dehiscence, which is called as a burst abdomen, these all are avoided. The heat loss of body in open surgery is also avoided. Faster recovery and very short hospital stay. Okay. MAS includes laparoscopy, thoracoscopy, endoluminal endoscopy, and arthroscopy, intra-articular joint surgery. Everything is coming now. Now they have gone few steps ahead. Usually we go for 3 to 4 truckers. In appendix we go for 3 truckers. Gallbladder 4 truckers. And now the technique is SILS. It is single incision laparoscopic surgery. What they are trying to do? Incision is somewhat long. 2 centimeter incision in umbilicus. And all the ports are introduced through umbilicus. So even that multiple small dots of 5 mm port will not also be visible. But it has got its own restrictions. Because here this technique is highly demanding and due to sheer size of 2 centimeter, post-operative herniation is common. Next is very commonly done now, taking over is NOTES. NOTES, short note may be asked. What it is? Natural orifice transluminal endoscopic surgery. The word itself says you are entering through the natural orifice. And what are the natural orifice? Mouth, rectum and other organs where you can directly enter into peritoneal cavity. Okay. So this is a technique of entering a peritoneal cavity. Nowadays the thyroid is also operated through the axilla. You can get a good exposure through the axilla also. It is not a natural opening. But this requires a higher technology and higher techniques. Notes commonly done in females, cholecystectomy, appendectomy and thyroidectomy. It is also important for staging of malignancy, segmental colectomy and gastrostomy. So this is regarding notes. You must be able to write down something regarding notes. New technique of laparoscopy through natural opening. Okay. And this concept also, retroperitoneoscopy. You are entering behind the peritoneum. So it is also become very popular. This is mainly popular for urology, kidney, ureters and most important adrenals. Adrenals can be very easily operated through this. What are you doing? Very small line approach, we are extending by inflating balloon. Every time a large balloon 50-60 ml is inflated and space is created. And in the space you can comfortably operate it. So what are the procedure done through retroperitoscopy, nephrectomy, pyeloplasty, pyelolithotomy and RPLND. If you remember our last lecture, what is this? Retroperitoneal lymph node dissection. When we do it? In cases of a carcinoma of the testes. More commonly in teratoma, sometimes in seminoma, because seminoma are more sensitive to radiotherapy. And teratomas are radio resistant. In those cases, along with high archeriotomy, we have to go for RPLND. It is our last lecture. Okay. And now, new surgeries done by these techniques are prostatectomy, but they are done through robotic. Thyroid, parathyroid, aortic aneurysm, single vessel coronary artery bypass, video assisted VATS, thoracoscopic, and hernia. So these are the commonly done surgery nowadays through a laparoscopy. So in short, laparoscopy, we know the technique, we know the limitations, we know the complications, we know the indications, and we know the advantages. This is fair enough to write a full question of 10 marks for a laparoscopy. You must know the technique and you must know the entry points of a scope. Okay. Now we go to our next question. This question is just now asked in your exam for 2017 probably, and I am proud that all our students have written very good answer, but unfortunately few of you has not even get the time to answer it. I don't know what they are busy in doing, but they didn't answer. More than 30% of the students have not appeared for examination. I think it is not a fair thing. If possible, always try to write down something. This will give type of revision. What we are doing is a revising. Even our question answer is a revision. Everything you know. Only we are trying to compile it. Okay. So this wound healing, most commonly asked, short note, full question. We'll compile what is a wound as such. What is the definition of a wound? There are two things, wound and ulcer. Both are same, but their area is different. What is wound? It is a break in the integrity of the skin or tissues. Here remember, skin and tissues and may be associated with disruption of structure and function. This is a wound, mainly for the solid organs. Wound is simply a disruption of any tissue, soft tissue or bone or internal organ. Anything comes under the definition of wound. As against, ulcer is also a wound, but it is a break or disruption in the continuity of a lining. That lining may be skin, but more commonly mucous membrane on other mucosal sites. Okay, this is the differentiation. Mucosa or skin only affected is ulcer. Any soft tissue, bone or skin affected, wound. So ulcer is one of the type of wounds. Okay, very clear now, wound and ulcer. Wound is a disruption of any tissue or a break in the integrity of skin or soft tissues. This is a definition of wound. Ulcer is a discontinuation or disruption in the mucosal membrane. So we will go to wound classification. This is always asked. This Levant Bailey photograph has given a beautiful everything in one chart. He has given different classification. There are many, but he has summarized in 4 classification. Classification 1, simple wound, complex wounds. Very simple. What do you mean simple wound? Only skin is involved. And complex stands for associated structures like vessel, nerve, tendon or bones. It is a complex wound. If bone is involved along with skin, what we call it? We call it a compound fracture. We do not call it a wound. We call it a compound fracture. So simple wound, complex wound. Closed wound, open wound. Differentiation. Closed wounds are contusion, abrasion, hematoma. Closed means where skin is not disrupted but it has been traumatized. Wound is there. Though skin is not erupted, skin is not divided, there is a wound, and that wound is contusion, abrasion, hematoma. In open wound, it can be incised wound, lacerated. Lacerated we always call as a CLW. That means contused and lacerated wound. This is a common word in medical legal, CLW. Patient came with a CLW of 4 cm, 3 cm. It is a laceration. Laceration is irregular wound, crush injuries and penetrating wound. They are all in the category of open wound. For us, wound is for a surgical, whether the wound is a tidy, that is a clean wound, or untidy means infected or likely to be infected wound. This is the simplest classification. It is, we'll consider in detail this classification. Tidy wounds, untidy wound. For a surgeon, when you are operating, there are again classification in 4 categories. First is clean wound, clean contaminated wound, already contaminated, and dirty wound. These are the 4 types of wound for a surgeon. First, tidy and untidy. Second is these 4 classification. We will consider these in detail. So there are basically 4 classification: simple, complex, closed, open, tidy, untidy, clean, contaminated, and clean, dirty. The first is clean, last is dirty. So remember all these 4 classification you must be able to write. So this classification, why is there so many classification? Type of wound, thickness of wound, surgical wound, duration. Duration also important. Primary, secondary, and level of infection. How much the infection has already occurred. The simplest classification is tidy and untidy. It is also called as Rank and Wakefield classification. If possible, try to remember the name. Tidy wounds. What are the tidy wounds? They are the incised wounds. What surgeon is giving is a tidy, clean-cut wound or any wound caused by a sharp object. That is a tidy wound. It is incised and clean. There is no associated tissue loss, because moment tissue loss is occurred, it is going to untidy wound. And the management for this is primary suturing. And the end result is primary intention healing. So we are going to what? Intentions of healing. For a tidy wound, it is a primary intention. As against that, the untidy wound due to crush injury, tearing force, avulsion, devitalized injury, vascular injury, and multiple irregular wounds, and burn. All the burns wounds are untidy wounds. Okay, and what happens here? In our clean tidy wound, intention is a primary intention, and in all untidy wounds, it is a secondary intention. Remember, this is very important. Tidy wound, primary intention. Untidy wound, secondary intention. That means all complications and drawback of secondary intention. The God should give you primary intention healing, because nothing will look in. So this graph also shows tidy, untidy classification. Tidy is incised, clean, healthy tissue without tissue loss. As against untidy, crushed, contaminated, devitalized, and usually tissue loss. So this is a tidy, untidy classification. Next, this indication is for us, for a surgery. Classification of the surgical wounds, always asked. And they have got their own importance. It is not only classifying. Once you classify, you have in your mind their clinical presentation, their management, and ultimate treatment and prognosis. Classification doesn't mean that it is just killing time. No, you are making everything in chart. We know once you talk a clean wound, you are saying many things. Okay. Once you say clean wound, we know that infection rate is minimum, it is less than 2%. When you say clean contaminated wound in surgery, infection rate is 10%. Understand how the gravity is increasing. When do you get clean contaminated wound? Like all surgeries of appendix, bowel, gallbladder, and pancreas, because they are not primarily infected, but they stand getting infection because they are already infected by organism. Appendicectomy is an inflammation of appendix. Cholecystitis is a inflammation or infection of a gallbladder. Pancreatitis is infection of pancreas. So you are operating over a infected tissue. That makes the rate of infection up to 10%. Third category, contaminated wound. Again, you are going one step ahead. Where the wound is already contaminated, you are operating. That means you are facing more likely infection. You have to take more care. In contaminated wound, it is 50 to 30%. What are the conditions? Usually for us, all accidental wounds. All roadside wounds stand in contaminated category, and all acute abdominal conditions like perforation peritonitis, they stand in contaminated wound. Next comes dirty infected wound. This is a stage D. One step or many steps ahead. What is it? Patient has already come with pus. So there is no question we are giving him pus. We are not giving him infection. He has come infected, and our attempt is to improve him. So what happens? Infection rate is 40 to 70%. From clean wound, we are going to 40 to 70% by the category. So categorization is important for the level or chances of infection. What are the examples? Abscess, PIOC, empyema of gallbladder, and worst is fecal peritonitis. Understand? What do you mean by classification? What are the implications of classification? So we understood the classification of wounds. Now comes the most important part, how the wound is going to heal. You must understand this basic. Unless you understand how it is going to heal, how are you going to help it? Primary intention, okay, you don't have to do anything, take suture, wound will heal on its own. But what about rest? There you have to go for active management. So what is the wound healing? Wound healing is a complex method to achieve, remember two words, anatomical and functional integrity. Two things are equally important. Anatomy is for realignment. Function is a deeper structure. Nothing has to be compromised. Functional integrity of disrupted tissue by various components. In wound healing, all the components are coming into play. It is a complex mechanism. That means there are complex ways of healing. The primary healing is what is called as a first intention. Primary healing is first intention. First sight, okay, you are happy. Everybody is happy, wound is clean, incision taken, sutured, no heal, patient is also happy. What will happen here? There is more of epithelial regeneration. Getting the difference? Epithelial regeneration is normal. Healing by fibrosis is secondary. So we don't want healing by fibrosis or collagen. This is primary intention. Your intention is very good. And what you get is a linear, smooth and supple scar. Remember, this word is very important. If scar is supple, it is not adherent to deeper structure. It is not painful. You won't remember that you have been operated. After 1 year, you have to find out where is the scar. And with the help of this laparoscopy, what we discussed, there are no wounds. Okay, how we are going to go for first intention? Primary healing is the first intention. Types of wound healing. Secondary healing, second intention. Not very happy, but it is a must. What it occurs? Whenever there is associated tissue loss. Whenever there is a loss of deeper structures, one has to go for second intention or a secondary healing. The commonest example for us, unfortunately, all major traumas. All roadside accidents come under secondary intention. All infected wounds come under second intention. All burns, particularly partial thickness deep burns, come under second intention. And how they heal? They heal by fibrosis. Ultimately, what they are getting? They are getting a hypertrophied and contracted scar, leading to disability. So this simple intention has caused disability. So our all aim should be go for primary intention. And reepithelialization. How the wound heals? Wound heals from the periphery. Remember this basic truth. Wounds do not heal from center. They heal from the wound margin and their speed is very low. That is why it takes 2 weeks, 3 weeks, 4 weeks, 6 weeks for the wound to completely close, and closing is by fibrosis. More bad than that, tertiary healing. What is it? Healing by third intention. First, second, third, last. What is the third intention? It is also called as a delayed primary intention. Your intention is good, but you are going by delayed technique. If possible, after the wound debridement, whenever the suturing is not possible due to infection or local causes, you have to leave it like that. There is no point in taking under tension. It causes more complications, more necrosis, and chances of a worse thing, gas gangrene. So no wound should be closed under tension. In secondary or delayed primary, you may close the suture or you may cover the wound with skin graft. Okay. By third intention we mean delayed suture or a skin graft. And this is also a tertiary intention. So we have primary intention, secondary intention, tertiary intention. All intentions are good, but results we don't. It depends. Then comes the most important question, stages of wound healing. Question not very liked by everybody, but it is always asked. And mnemonic goes by the name IESM. Stages of wound healing, IESM. I stands for inflammation. All the wounds start healing by inflammation. It is a tissue trauma. E stands for epithelialization. S stands for scar formation and M for maturation. So these are the stages of wound healing: inflammation, epithelialization, scar formation and maturation. 4 stages. Stage of inflammation, stage of epithelialization, stage of scar formation and resorption. Again, whatever is extra is reabsorbed, trying to give more shape to the wound, and maturation. Okay, these are the stages of wound healing. They are also called as phases of wound healing. So what are the stages of wound healing? IPR, inflammatory stage, proliferative phase and remodeling phase. You must remember this. Inflammatory phase also called as exudative phase. So many names. Just remember 1 or 2 names. Okay. Inflammatory is sufficient. When it begins immediately after wound. And till healing it lasts. How much? It lasts for 4 to 6 days. Inflammatory phase lasts for 4 to 6 days. And what are the features? All stages of inflammation. Always remember, you must be knowing this from your first MBBS. Rubor, Keller, tumor, dolor and loss of function. These 5 things. 5 things are indicative of inflammation. 4 to 6 days. Proliferative phase, second stage. This is fibroblastic phase or collagen. What they are producing? The collagen healing material is produced by fibroblast. The moment fibroblast comes, there is going to be hypertrophic scar or keloid. This stage begins after 7 days, after the inflammation has done its job. Proliferative stage from 7 days and it lasts for 6 weeks. So this is by secondary intention. It is a long phase. 7 days to 6 weeks. First stage 4 to 6 days, 7 days to 6 weeks, and the third is maturation phase or remodeling phase. R stands for remodeling. I for inflammation, P for proliferation, R for remodeling. This stage, though start after 6 weeks, can remain up to 2 years. See the duration. The wound getting completely mature takes a very long time, because once the natural things are disturbed, unnatural things or attempts take very long time. So what happens? The scar may not be always. Scar will be hypertrophic up to 6 months, collagen after 6 months, and this all occurs because of a cross-linking property of a collagen. It is not a straight linking, it is a cross-linking which gives rise to tensile strength. In red pen I have written collagen production is not present after 42 days of wound healing. That means up to 40 days all collagen is deposited. After that it is only linking. The collagen linking keeps on going. And very important thing always asked, the wound never regains its natural strength. The natural strength of a wound or skin is never regained. Maximum you can regain is 70%. Out of this, all attempt by nature for healing. Then, the most important question, what are the factors affecting wound healing? Last time also it was asked and you have written beautifully. There are two factors. First is the local factor, another general factor. Local factors are, if you know very well, primary and most important is dead tissue, a foreign body in the wound, and infection. These three are primary factors which will affect the wound healing. Infection, necrosis, and foreign body. Why necrosis occurs? Because of a crush and poor blood supply. At the same time, during healing, the dead material has to be taken away by the lymphatics. If there is a blockage of lymph or venous, again the local factor. Tension. If you take the wound under tension, again healing problem. Formation of hematoma, again healing problem. Poor apposition, again healing problems. Recurrent trauma. That means you know in children, many times they keep having trauma, same place. This is very common. Once you get trauma, that structure becomes vulnerable. Anytime the son will come with the same, I got trauma here. So mother is also know that he always get trauma there. So it is a recurrent trauma. Radiation. The radiated areas are comparatively poor to heal because of a blood supply. Joint. What happens? Over the joint, there is always a movement. So movement is local factor which will affect the wound healing or delay the wound healing. Back. All the wounds over back have got a poor healing property because of a less blood supply and less sensation. All the bed sores primarily occur where? Back. Mainly over the buttocks. Okay. Or the ischial tuberosities. Heel. These are the area where the bed sore always occur. Associated disease like osteomyelitis or malignancy. And why the wound has occurred. And tissue hypoxia. So these are all the local factors. Remember, infection, necrosis, foreign body, blood supply, enough, hematoma. That is more than enough. You write down this. Okay. Now the general factors. Apart from local, there are the non-modifiable factors like age. You cannot modify. Old age, poor healing. In children, healing is very good. Smoking. Smoking is one of the important cause for delayed healing. One must stop smoking. Nowadays, there is dictum, even if somebody is smoker, he should stop smoking at least 1 month before surgery. This is a guideline now from WHO. Ask the smoker to stop smoking 1 month prior to surgery. Okay. Malnutrition, vitamin deficiency, anemia, malignancy, uremia, jaundice. Jaundice is also major cause for non-healing. Diabetes as usual always there, all diseases, and HIV, that is immunocompromised patients also had a poor healing. Same time, any neuropathy because of any cause, if the patient is taking corticosteroids, that also affect healing, and cytotoxic drugs, that means patient taking anti-malignancy drugs will also have a poor healing. So we have considered local factors as well as general factors. And what are the influencing of the wound now? In general, look at it as a whole. Influence healing over the wound. First and foremost, where the wound is. Site of the wound. What are the structure involved? How the injury has occurred. That is mechanism. Incision, crush plus avulsion, grade 3. Contamination, loss of tissue, vascular insufficiency, radiation, pressure, and all systemic fractures like we have considered steroid, diabetes, and AIDS. So these are all factors which are going to affect the wound healing, local factors and general factors. Okay. So we have considered the wound healing. we have considered two major problems first. First is laparoscopy and second is wound healing. This wound healing, if you combine, you can write down full question or short note, whatever is asked. The next question we are dealing is describe the, now we are going to systemic surgery. Etiology, pathology, clinical features and management of a perforated duodenal ulcer. This is one of the most common emergency where a general surgeon comes to face. Ulcer perforated are very common. The reason why they are more common now, people say there are different reasons, but the commonest is NSAID. NSAID is a major cause and second is H. pylori. So these two are the primary causes for ulcer perforation. When you talk of ulcer, ulcer perforation is synonymous with either gastric perforation or a duodenal perforation. Okay, and there is no clinical differentiation which is possible between the gastric and duodenal perforation. In old age, we always used to talk pain before food, pain after food. Nowadays, that has become very vague boundaries. You can diagnose only on endoscopy. So, what are the main complications of all ulcer? Commonest complications are perforation and hemorrhage. So, we will going for peptic perforation. This love and belly graph is beautiful. If you remember this much, you can write everything and you are passing. Peptic ulceration. Most peptic ulcers are caused by H. pylori. Now H. pylori is a buzzword. You must know everything regarding H. pylori or NSAID. Why NSAID? Because taking this commonly even on counter and mainly in old age is indirectly helping the ulcers to remain chronic and to perforate. It is a major cause of epidemiology in ulcer lifestyle. Okay, H. pylori and NSAID. The duodenal ulcers are more common than gastric ulcers. Which is more common? Duodenal ulcer. 75%, 25% of gastric. But the symptoms are indistinguishable. We have considered everything clinical now. Next, gastric ulcers may become malignant as against ulcerated gastric ulcer may look like a benign ulcer. That is why biopsy from gastric ulcer must be taken. Okay. Gastric anti-secretory agents and H. pylori eradication therapy are the mainstay of treatment. That means what we are giving these proton pump inhibitors and H. pylori eradication, that means antibiotics, 3 antibiotics are taken together for H. pylori is the mainstay of treatment of any ulcer, and elective surgery is nowadays rarely performed. So we have talked about the management. Complications. Now complications of what? Why we are not doing surgery? Because peptic ulcer surgery has got a more of long-term complications and they are very difficult to treat. That is why surgery should be avoided. In a planned surgery, I mean surgery is planned surgery in a ulcer case. Commonest complications are perforation, bleeding and stenosis. If you remember our last lecture, we talked about GOO, that is gastric outlet obstruction, and commonest causes pyloric stenosis or carcinoma of the stomach. क्यों सर? आपका पेट रहा है वो लेके गया? थैंक यू. आप बहुत डिटेल है सर. आपका लेक्चर अच्छा था. मैं पढ़ा सुना पूरा मैं. Thank you. So common complication is perforation, bleeding and stenosis. And the treatment of a perforated peptic ulcer is primarily surgical. Rarely, if patient come very early, can be managed conservatively. So you have written a full question on peptic ulceration. These 6 to 7 points summarize everything. You have to add first, if not, but here and there, and you are through. Okay. So let us consider, because we have to go through it. So what is a perforated peptic ulcer? Perforated peptic ulcer is terminology used for both gastric ulcer perforation, DU perforation, and now added another son is a stromal ulcer. What is stromal ulcer? Whenever you operated for gastrogenostomy or something, the ulcer form over the stroma of the anastomosis. That is a stromal ulcer. Otherwise, everything is common. DU perforation is 75%, and incidence is sustained and increasing because of NSAID use in elderly. And remember, 80% of perforated duodenal ulcer are H. pylori positive. That means H. pylori eradication must take a primary role in the management of any ulcer. One more thing, pain is different. Men are more affected than women, and ratio is right from 12 to 20 per 1 against 1. That means 12 to 20 male against 1 female. What it conveys? This is a beautiful thing you must remember. If a patient of a perforation, if a woman comes to you with a pain in abdomen or symptoms like perforation, do not suspect perforation. You have to suspect something more than that. That means because it is not very common in women. Women do have ulcers, but they don't perforate. Because anterior ulcer perforate, posterior ulcer bleeds. Okay, so don't suspect perforated duodenal ulcer in women. Always consider perforated ulcer in men. The cause is alcohol and smoking. So what are the causes? Primary is non-traumatic. Non-traumatic means gastric ulcer, duodenal ulcer, obstruction, ischemia, any loss of blood supply can cause ulceration, and malignancy. These are the non-traumatic causes for a perforated peptic ulcer. Traumatic causes is commonest is blood trauma. Commonest blood trauma or penetrant trauma. Now, addition to that, there is always a potential hazard of a perforation of a bowel through endoscopy. And while doing ERCP, you may perforate duodenum. Same time, foreign body can cause perforation, and ZD syndrome, that means gastrinoma. In gastrinoma, the perforations are more common. So, what are the precipitating factors? Without anything, you must write down Helicobacter pylori is a cause, and exam is happy. Aspirin, smoking, alcohol. So, these are common causes everywhere on earth for ulcer formation. So, coming to proper of a perforated duodenal ulcer. Males are common. Age is comparatively young age. May occur any age, but common is young age. Anterior ulcer perforate most commonly. In 80% of cases, patient does give history of a duodenal ulcer. But in 20% of cases, patient presents with perforation. So it is called as a silent perforation. Patient is not giving any history. And if it occurs in acute ulcer, that means after ingestion after alcohol, you must always suspect duodenal ulcer perforation. Precipitated by steroid, alcohol, and anti-malarial drugs. It was very common in our period. Taking 4 tablets of chloroquine always provokes or more likely to provoke ulcer perforation. So chloroquine you must take after food. Empty stomach, chloroquine is never advised. Nowadays, fortunately, the malaria itself has gone down. Overall incidence of perforation is 5%. Active ulcers perforate more commonly. NSAID ulcer more elderly. And unfortunately, the mortality in a perforated duodenal ulcer is 10%, and in a gastric ulcer it is 20%. The reason is gastric ulcers are comparatively large. Okay, this is the size itself matters. Because of a large size, fluid comes out very easily. So, how does the manage? How it is clinically presented? So, what are the stages of perforation? You must know what is happening. The moment perforation occurs, what happens? Being part of stomach, the acid comes out. Acid comes out and it immediately inflames the peritoneum, and that is a very severe pain. And it is a chemical peritonitis. Understand? The chemical acid, bile acid has come out of a perforation into peritoneum, into abdominal cavity. So it is a stage of chemical peritonitis. It is immediate. Immediate patient present with severe epigastric pain, vomiting, tenderness, guarding, rigidity and tachycardia. Everything come together. Next stage, it is a stage of illusion. What actually happens? The fluid may come out 10-15 ml or something like that, but the peritoneal fluid will dilute it. It will be diluted, and because of a major dilution, pain is temporarily reduced and patient feels better. This is where you may miss the diagnosis. This whole period lasts for 6 hours. Okay, and after 6 hours, what? It is a diffuse bacterial peritonitis. Again going back to every symptom. After 6 hours, the organisms comes out of the perforation and they cause diffuse peritonitis. Then the whole pus is inflamed to all over peritoneal cavity. Okay. So 3 stages. First stage is chemical peritonitis, stage of reaction, and third stage is diffuse bacterial peritonitis. Usually lasts for 24 to 48 hours. So clinical features. Very common, very simple. Severe persistent pain in epigastrium. Sudden in onset. Radiation to right scapular region because the pain is near the diaphragm. Right diaphragm is very near to the DU perforation site. Pain is more on movements. So patient has to lie down still on the bed. He doesn't want to move. Tenderness or rebound tenderness. Clinically, you must know tenderness is the feeling pain patient gives on touching or pressing the abdomen, and rebound is whenever you take your fingers away from the abdomen, and it is called as a Bloomberg sign. It is seen usually all over abdomen in late stages. Fever, vomiting, dehydration, oliguria. Toxic, tachycardia, late stages, abdominal distension, guarding rigidity, dullness. Now the fluid is so much that it is causing dullness over the flanks. That means the fluid is more than 500 ml. Obliteration of a dullness, liver dullness, that is the say about 9 to 10 space. What is this? Because of a gas which escapes from duodenal perforation, it comes above the liver and below the diaphragm. That means gas is now between the liver and the diaphragm, and that area becomes resonant. It is called as a sign of a liver dullness, and you have to make use of all 3 fingers, 1, 2, 3. All 3 fingers and middle finger will be resonant. If all these 3 fingers are resonant, you are going for a obliteration of a liver dullness. This goes in favor of a gas under diaphragm, that is perforation. And if you go for PR, tenderness can be felt. This syndrome, if possible, remember Valentino syndrome. What does it say? Perforated peptic ulcer coming after 12 hours. They mimic acute appendicitis, and very commonly diagnosis is missed because in 10 to 20% of DO perforation, gas is not seen in the diaphragm. Okay, only USG what shows us? USG shows there is a fluid in the abdomen. Air is not there. Now the tenderness has come to right iliac fossa because pus, where it will go? The pus will accumulate into right iliac fossa and pelvic cavity. That is why tenderness has come from upper abdomen to lower abdomen. It is called as a Valentino syndrome, where peptic ulcer mimics acute appendicitis. Okay. And the investigation. Everybody knows the investigation, basic investigation. Erect abdomen X-ray. Remember, 70% of the patients show gas in diaphragm. 30% do not show gas in diaphragm. USG abdomen, all blood investigation. CT abdomen. It is most sensitive whenever there is no air under diaphragm. In that case, you must go for CT. So, what are the differential diagnoses? Commonest: acute appendix, acute pancreas, every acute condition, acute cholecystitis, and unfortunately ruptured aortic aneurysm. This you should never miss. Sometimes myocardial infarction pain also mimic peptic ulcer perforation, and worst is mesenteric ischemia. Sometimes pneumonia. Why pneumonia? Because lower lobe pneumonia on right side will mimic the inflammation of the diaphragm. It comes same as like perforation of the DU. Okay, these are differential diagnosis. How are we going to treat it? Most of the patients need surgery for a DU perforation. So what is the first thing? Admission, IV fluid, antibiotics. A rise tube aspiration is the mainstay, because here you are removing the fluid, and what you are doing? If you don't remove the fluid, this fluid will again go into the abdomen, because the opening is already there. Now it is a very simple job for the fluid. So you have to put a rise tube and start continuous aspiration. Catheter for the management and knowing the hydration condition. Surgery is the mainstay. How do you classify an ulcer? When you say small ulcer, if they are less than 1 centimeter. You call it large ulcer if they are 1 to 3 centimeters. You call it giant ulcer when? If they are above 3 centimeters. This is for MCQ. Giant ulcer more than 3 centimeter, large ulcer 1 to 3 centimeter, small ulcer less than 1 centimeter. Surgery is emergency laparatomy. Commonest incision is upper midline. You have to suck all the fluid, wash abdomen, and you have to suture the perforation. Along with that, we are giving what? Omental patch. That is a reinforcement. Different techniques like Cellar zone technique. Commonly what to do is Rose-Graham's patch. What is Graham's patch? It is a free omentum is taken from the omentum cut over. It is a free omentum and suturing. Graham's patch. Modified Graham's technique, you are taking a pedicle of the omentum, not cutting it. Directly the omentum is attached over the perforation. It is closed. Because of adhesive property, there is a very good sealing of the perforation. So this is the management. Along with that, peritoneal toilet is a must. Drain has to be kept, and whenever the patient is discharged, you must ask him to avoid alcohol and take proton pump inhibitors for 6 to 12 weeks. Why? To avoid a reperforation. Nowadays, gastroscopy is advised after 12 weeks, and H. pylori treatment is mainstay without giving any compromise for this. If you don't do that, patient will again have perforation. So, if suppose possible, in our days we used to go for a concomitant procedure. What procedure? Like highly selective vagotomy, truncal vagotomy, pyloroplasty and gastrogenostomy was done in old days. What we thought regarding that? We will reduce the chances of a perforation again. But at present, we are not doing it. Our is a primary management of a closure of perforation. And with the help of H. pylori, the reperforation chances are gone down. So we have finished regarding the perforation. This one will finish it short. This question is also asked regarding hydronephrosis, that is HN, hydronephrosis. What it is? A septic dilatation of a pelvic calyceal system. Why it occurs? It is mainly due to partial or intermittent obstruction to the outflow of urine. Complete obstruction will not cause dilatation. Remember, it is a partial and intermittent. Intermittent is most common cause, which will go for hydronephrosis. Causes of hydronephrosis, question asked. Unilateral different causes, bilateral different causes. In unilateral, there are 3 causes: extramural, intramural, and intraluminal. Getting it? Extramural, that means something pressing over the ureter. Aberrant renal vessel, more common on left side. Growth, carcinoma cervix, CR rectum. Retroperitoneal fibrosis and congenital cause, retrocaval ureter. What are the intramural causes? That means inside the wall. Intramural is wall. Okay, mura is wall. Extramural, intramural. Intramural, congenital PUJ obstruction, neoplasm, and strictures. Intraluminal, that means in the lumen itself. Wall has nothing to do. Commonest cause is stone and whenever sloughed papilla by necrosis or a unilateral. If it is bilateral, basic cause congenital. Commonest cause is congenital stricture of external urethral meatus. This is the most common cause. And pinhole meatus in children, if not treated for a long time, it can cause bilateral hydronephrosis. And PUV, short note, posterior urethral wall, is most common condition in pediatric males. And what it causes? It causes bilateral hydronephrosis. Acquired causes in adult: prostatic hypertrophy, carcinoma of prostate, bladder neck scarring, and all traumatic causes. In female, carcinoma cervix and carcinoma of bladder proper. So these are the causes of hydronephrosis. And in red pen I have written congenital pelviureteric junction obstruction or congenital PUJ, pelviureteric junction, is the most common cause for hydronephrosis. And remember, it is usually bilateral and one of the side may present earlier. So which is a common cause for hydronephrosis? Congenital pelviureteric junction. That is a stricture. Patient may have aberrant renal artery. So how do you classify the hydronephrosis? Simple. Classification 1. Unilateral hydronephrosis, bilateral hydronephrosis without renal failure, and bilateral HN with renal failure. So many classifications. Classification 2. Intermittent, persistent. Intermittent is more common, important for us because whenever the obstruction occurs, swelling and pain occur in the loin, and whenever patient passes large amount of urine, pain will disappear and swelling will disappear, and what it is called as Dietz crisis. Remember, for a short note, Dietz crisis is the passing of a large amount of urine after which pain disappears in case of a congenital PUJ. Third classification, only hydronephrosis or hydronephrosis hydrorenal. Fourth classification, extrarenal pelvic. Remember, in anatomy you are taught the pelvis can be intrarenal, pelvis can be extrarenal. Commonest is extrarenal pelvis, which is called PUJ, and destruction of kidney. This figure shows aberrant vessels. So what is the pathology? It is an intermittent pressure burden over the pelvis, and whenever the thickness below 2 millimeters, remember, if the thickness of cortex go below 2 millimeter, kidneys are less likely to function. That means you have to interfere at earliest. So what are the features? Congenital, PUJ and calculus are most common causes. Male to female, 2:1. Right kidney, more affected. Dull pain, mass, which moves with respiration, always attacks of renal colic, and patient having Dietz crisis are diagnostic or clinical features of a congenital PUJ, hydronephrosis. Sometimes patient can have dysuria or hematuria, and there can be associated hypertension. These are the clinical features. In bilateral, same thing in a more fatter. Bilateral loin pain, the complications are more here. Pyonephrosis, perinephric abscess, and renal failure in bilateral cases. So what are the causes of renal failure? Commonest cause is polycystic kidney, and next is hydronephrosis. Okay, you remember this. Investigation done, all blood investigation like urea, creatinine, urine, microscopy, USG abdomen is a IOC. Investigation of choice is USG. One may go for intravenous urethropy, CT scan and isotope It is for the function. For the function, you must go for isotope and one test, if possible, remember, Whitaker test. Here, fine needle is passed to the renal pelvis and you push a saline. After some time, the saline will go, but the pressure will remain same. It goes in diagnosis of a congenital hydronephrosis, Whittaker test. Treatment, usually conservative surgeries, because you want to save the kidneys. Remember, kidneys have not done anything bad. Kidneys are there. It is the pressure from below which is causing kidney pathology. So, nephrectomy is not done unless grossly damaged. Cause is treated first. Causes like stone, anomaly, phimosis, BPH and PUV. This treatment is systemic fulguration of wall. The surgery is Anderson-Hines operation. Very common, they may ask. Anderson's operation is dismembered pyeloplasty. Very simple. You cut the pelvis, resuture it. Okay. You make it short. You make it direct. So it is dismembered. You have just changed the configuration of a pylorus. And what you have done here? Initially, ureter was at the independent position. Now you have made it the dependent position. Simple operation. Okay. And this is what is sometimes done and was a non-membered is Foley's viviplasty. Remember, only Anderson-Hines surgery of choice. Okay. And last is very small, clinical features and management of a malignant neoplasm. This is very simple and short question. What it is? Remember, chronic malignancy is a hypernephroma. What are the names? Hypernephroma, Gravity's tumor, clear cell carcinoma and internist tumor. These are the different names given to malignancy of a kidney. Among them, hypernephroma is a misnomer because it is not standing above the kidney. It is a part of kidney. It is adenocarcinoma. It is common in males. Okay. Clear cell type 75%, papillary 15%, chromophobe 5%, and collecting duct of Bellini 1%. But just remember, clear cell carcinoma and papillary are commonest for adenocarcinoma of the kidney. Hypernephroma is an adenocarcinoma. What is etiology? It is associated with so many conditions. If possible, remember or forget. But if you can remember von Hippel-Lindau disease, very good. Don't remember, you say it is congenital condition. But now, when you take a high amount of animal fat, it is more likely to cause renal cell carcinoma. Be aware of that. Environmental factor, asbestos, lead, cadmium and tobacco. Again, tobacco is coming into play. Remember, for all urogenital malignancies, particularly bladder and below kidney, it is the tobacco and the dyes. Many of them are related to the profession. So, dye is a major cause for carcinoma of the bladder. Cadmium asbestos is common for carcinoma of the kidney. Chromosomal aberrations, acquired kidney disease, different syndrome, and cortic angioplasty, analgesic nephropathy. Remember, only this, it is a congenital condition caused by fat and also caused by different types of lead, cadmium or the dyes. And major problem is tobacco. Okay, this is more than sufficient. How does it spread? It spread by local spread, it spread by blood spread or lymphatic spread. Very simple. TNM classification, it was done 2018, but nowadays they have come out with a very simple calculation. I will tell you that in the end. TNM classification, remember, for a kidney malignancy, most of this depend on the size of the tumor. What is significant is up to 4 to 7 centimeters, T1A. Moment it goes above 7 centimeter, it is T2. If it is T2B, it has to be more than 10 centimeter. T3 is extension. What is extension important? It is a Gerard asphyxia, because Gerard asphyxia is covering the whole kidney and trying that nothing passes it. The moment malignancy passes it, it go to T3. Whenever it invades Gerard asphyxia and extend beyond, it is a T4. So whatever is a structure which is preserving has been evaded. That goes to T4. Lymph node, NX, N0, N1. N1 is spread to lymph node. Blood spread distance commonly to lung and soft tissue both. They are favorite. Lung and bones are always favorite of any distant metastasis. He always say lung and bone, you are through. Okay. And clinical features. This you must remember. For a triad of renal cell carcinoma, it is pain, hematuria, and palpable renal mass. Write down three things, more than enough. What is the pain? Dragging discomfort. Mass in line which moves with respiration. Why kidney moves the respiration? Because it is in contact with diaphragm, either through liver or through kidney. Dull pain in a renal angle. One thing, on a left side, the varicocele is very common and it is irreducible. In a varicocele, you must write down left-sided malignancy of the kidney can give rise to irreducible varicocele. Sometimes they present as a secondary. Pathological fractures, hemoptysis, and for this it is a PO. Many patients of unknown fever in old age can have carcinoma of the kidney. Other symptoms are main, malaise, all malignancy, malaise, lethargy, severe anemia. Okay. And what is the treatment of choice? It is very simple. Surgery of choice, investigation, sorry. Microscopy for RBCs because there is bound to be hematuria. Visible, non-invisible. This is latest classification. Never forget this. Visible malignant, visible RBCs, non-visible hematuria. Okay. IVP, USG, CT scan, CT chest for secondaries. Bone scan, MRI. How do you differentiate? Differential diagnosis, DD, polycystic kidney, solitary cyst of kidney, adrenal tumor, retroperitoneal tumor and carcinoma of colon. Treatment, simply say surgery is the treatment of choice. Okay. Once surgery is done, whatever you are going to remove, it is entire kidney, tumor, perinephric fat, ipsilateral adrenal gland, not bilateral, and lymph nodes. Why surgery? Because these tumors are radio resistant. But chemotherapy can help. And what is chemotherapy of choice? Vinblastine plus progesterone. What is the prognosis? 5-year survival is 40%, not very good. If it is early diagnosed, 70 to 90%. 5-year survival for 1 and 2 stage, 65%. Stage 4, 10%. So it all depends on staging. So this, if possible, go through this. These are all general things. Most common site, most common tumor, and age, risk factors. Preoperative biopsy is necessary. Remember this thing, very important. Preoperative biopsy is not necessary in renal cell carcinoma because RCC is 95% most common in kidney. So any mass in renal cell carcinoma is proved in kidney is proved to be malignancy unless proved otherwise. So all mass in kidney must be treated as a malignancy. Classical triad, hematuria, flank pain, mass. And earliest and most common is hematuria. Staging, this is a very good staging. Stage 1, more than 7 cm in largest diameter. Remember, this is also important. How do it is not triangular. Any dimension more than 7 cm, it is stage 1. Less than any diameter more than 7 cm, it is stage 2. But it should be limited to kidney. Stage 3, involvement of major vein or adrenaline because now you are going nearer by. But here the Geritos fascia is not invaded. Stage 4, invasion of a Geritos fascia. So this classification is more beautiful and easy to remember. Less than 7 cm, more than 7 cm, Geritos fascia intact, Geritos fascia distant. Okay, all 4 grades. And it is called as a Fuhrman's grading system. Most common route for metastasis is hematogenous. And how does it go? It grows into renal vein. So you must ligate the artery first before going for nephrectomy for MCQ. Renal cell carcinoma produces pulsatile skull metastasis. Second condition to do that is follicular thyroid cancer. This is again for MCQ. Most common mets, lungs. And now these days, if it is less than 4 cm, we are going for partial nephrectomy. And if you remember this chart, you are the master of renal cell carcinoma. What it says? Localized RCC, advanced RCC. Less than 7 centimeter, partial nephrectomy. More than 7 centimeter, radical nephrectomy. Advanced RCC, palliative treatment. So all the treatment is over. And what does radical nephrectomy includes? Kidney and fascia, ipsilateral retinal, renal hilar lymph node, and proximal half of the ureter. Understand? This is for the localized. Advanced nephrectomy, chemo, radio not applicable, hormone therapy, immunotherapy. So this graph we have done all management of a renal cell carcinoma. If you remember this, I am sure you are going to get through in flying color. Thank you very much. We have taken slightly longer time. Sorry for that. And in next lecture we will consider 2011 discussion. Thank you very much. Good day.
పొద్దున నాశలేనా ఎందుకు మనకి 5 గంటలకు లేచాలి కదా దాని పనులు అవునా అన్నయ్య చేయలేదు అన్నయ్య లేదేసిందా అవును ఏదో విన్నాడినా అవును అయితే మాట్లాడతాను స్నానం చేసుకుని రేపు అడుగులు కూడా మళ్ళీ 2 రోజులు సరేనా నాకు ఏదో ఒకటి చెప్పు నువ్వు ఏం చెప్తాను ఫోన్ చేసి చెప్తాను సరేనా అవునా సరే నువ్వు వచ్చాను ఊరికి వచ్చాను ఊరికి అదే కట్టడా సరే సరే ఇప్పుడు ఎట్లా చేస్తున్నా కనుక్కోవడం కదా అట్లా పోతుంది కదా బ్యాంక్ కనుక్కొని అనుకోవాలి కదా సరే సరే ఎవరికి ట్రాన్స్ఫర్ చేస్తున్నా చేసి మరి ఎవరు పంపిస్తారు కదా అట్లాంటి అలా నువ్వు వాడి పోలేము కదా అదే అడుగుతుంది టీచర్ పోయిందా ఎన్ని గంటలు అయిందా నీకు 3 గంటలు అయిపోయాయి దాని దగ్గర ఉండదు రేపు ఎన్ని గంటలకు నువ్వు మనకు అనుకోవట్లేదు మరి ఎట్లా తెలిసింది చెప్తాను కదా మరి ముందే పోతే బాగా ఎందుకంటే 1 గంట ముందే ఉండాలి చెప్పలేం కదా తొందరగా వస్తే లేట్ వస్తుంది ఎందుకంటే ఒకసారి తొందరగా వస్తే పోయింది సరే మీరు కూర్చొని రాసుకుంటున్నారా నేను ఎప్పుడు ఫోన్ అయినా అర్థం ఫోన్ అయినా ఎప్పుడు ఈ రోజు రాసుకున్నాను No. Try. Later on, Class